for the teaching activity for the current year. And our speaker today is Dr. Mansoor Khan. Is an oncology-hematology pharmacy practice clinical pharmacist and working in King Abdulaziz Medical City, Jeddah. He has almost more than 20 years experience in hematology and oncology. And yeah, we're glad to have this session with him. So Dr. Mansoor, you can start.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone. Thank you so much, Dr. Afnan, for this invite, and it's an honor for me to present this topic of febrile neutropenia to our prestigious residents. So today we'll talk about the management of the febrile neutropenia. These are my objectives. We'll talk about the definition of the febrile neutropenia, the laboratory definition of febrile neutropenia. We'll try to stratify the febrile neutropenia patients based on a multinational association of supportive care in cancer, which is called MASCC risk system. And we'll review the international guidelines like NCCN guidelines and IDSA guidelines. And also we have our own guidelines at Ministry of National Health Affairs. And we'll review the different uses and indication of different classes of antimicrobials according to the different international guidelines. And we'll also touch upon antimicrobial prophylaxis, which is recommended in neutropenic patients. And our residents have published 2 or 3 studies as well. So we will try to briefly touch upon those studies as well with regards to the antimicrobial prophylaxis. Okay, so these are the latest resources. The IDSA guidelines for febrile neutropenia were last time updated in 2010, were published in 2011 actually. And clinical practice guideline by NCCN, which is National Cancer Comprehensive Cancer Network guidelines. These are updated every year, actually 2 to 3 times in a year. And we have American Society of Clinical Oncology guidelines, which were updated in 2015. And we had an update in 2018 about outpatient antibiotic management of febrile neutropenia as well. So what happens in febrile neutropenia? So let's try to understand the pathophysiology of the febrile neutropenia. So basically we give chemotherapy to patients, cytotoxic therapy to the patients. So this cytotoxic therapy or chemotherapy is not only toxic to cancer cells, but it's also toxic to healthy cells. So most of the chemotherapeutic agents are actually cell cycle specific agents. So they are rapidly targeting cancer cells, such as the bone marrow cells. These are rapidly proliferating cells, and as well as the GI mucosa, like mucosal membrane, GI mucosa throughout the anterior canal. These are the rapidly proliferating cells, and the chemotherapy hit those rapidly proliferating cells more harder. That's why we see the myelosuppression, we see the mucositis. So generally speaking, when we give chemotherapy, for example, let's say today, so we are expecting the patients will be having neutropenia after 7 to 10 days, because the half-life of the neutrophil is about 1 to 3 days. Let's say it is 3 days, so after 4 half-lives, we're talking about 10, 12 days. So there will be no more production of the neutrophils, and the circulating neutrophils in the peripheral blood will be going down in number, and as produces the neutropenia. And we are expecting the patients to have neutropenia after 1 week to 10 days of the chemotherapy was started. And this period is called nadir period, when we are expecting, when we are anticipating that the patient can have the maximum myelosuppression during a particular period. It's called nadir for the counts, and the nadir for the platelets and the nadir for the neutrophils are different depending upon their half-lives. And also the chemotherapy, as I mentioned, they try to target the rapidly proliferating cells such as GI mucosa as well. So when the barriers protected by the GI mucosa is broken, then the organisms, for example, in the oral cavity, like gram-positive organisms, they can penetrate into the bloodstream and can cause bloodstream infections. And the gastrointestinal mucosa, where normally gram-negative rods are harboring. So, for example, Enterobacteriaceae rods, which are most commonly found in patients with a febrile neutropenia in the bacteremic episodes. So the source is usually the GIT mucosa. So from there, like E. coli, Salmonella, Shigella, these kind of organisms can actually penetrate into the blood and can cause bloodstream infection. So that's important to understand, that when we give chemotherapy, when are we expecting patients to have the bone marrow suppression? So we're talking about 10 days, 7 to 10 days, and the maximum counts will be depressed from 10 to 14 days. So on an average, the median nadir for the neutropenia is about 10 to 14 days, and after 14 days, we're expecting the patient to recover from the count. So keep this number in your mind when I'm talking about definition of the febrile neutropenia. This will help you when I talk about the anticipation. So febrile neutropenia is an oncologic emergency. Like you have MI, myocardial infarction, a medical emergency in cardiology. So we have febrile neutropenia is one of the oncologic emergency, and it is significantly associated with mortality and morbidity if it's not treated immediately. So we have seen patients dying within days, within hours. So that's the reason whenever the febrile neutropenia patient comes to the hospital, we don't know when the patient comes to the hospital. So we take the history of the patient. So the patient tells, like, I took chemotherapy like 10 days ago, now I'm having fever. So you immediately anticipate that this patient is having febrile neutropenia. So there is fast triage in the emergency room of each oncology center or each hospital. So these patients, they have to be given fast triage, and you have to assess this patient quickly. I'm going to talk about that in a couple of minutes. And the antibiotic administration should be done within 60 minutes. There are studies which have shown that administration of antibiotics within 60 minutes reduces significant mortality and morbidity. And actually, in our hospital, we have the quality metric to measure actually that we are trying to administer the antibiotic within 30 minutes of patient's arrival in the hospital. And if the patient develops febrile neutropenia, that definitely compromises the efficacy of the chemotherapy. What you have to do, you have to reduce the dose of the chemotherapy, which may have obviously an decreased outcome on the clinical efficacy. But what we try to do, we try to use the growth factors and try to use the antimicrobial prophylaxis in order to maintain the dose density and the dose intensity of the chemotherapy, and to prevent the neutropenia, severe neutropenia, which is called grade 4 neutropenia. So the patient, those who come to the hospital who are at risk of developing a bloodstream infection, those who are having profound neutropenia. So we grade febrile neutropenia up in neutropenia in 4 to 5 different grades based on NCI CTCAE grading. So the normal neutrophil count is more than 2,000 to 7,500. And when it is less than 2,000 to 1,500 is grade 1 neutropenia, less than 1,500 to 1,000 is grade 2 neutropenia, less than 1,000 to 500 is grade 3 neutropenia, less than 500 is grade 4, and less than 100 actually still grade 4 neutropenia is called profound neutropenia. That's what we see in mostly AML and MDS patients. So these are the patients who actually develop the bloodstream infection. They are super immunocompromised patients, and they cannot even develop bacterial infection, and later on in the course of the febrile neutropenia, they can go on and develop like mold infection, a yeast infection, fungal infection, and viral infection as well. So here's a definition of the febrile neutropenia for exam purposes. If you are going to be tested by Saudi Commission Health Specialist exam, or you're going to be tested for BPS exam, so that's the definition that you need to remember in your mind. So the definition includes two parameters: number one, fever, and then the neutropenia. So the temperature of 38.3 degrees centigrade once or over 38 degrees centigrade for more than 1 hour. And it is you have to meet both criteria. And neutropenia of grade 4, which is considered neutrophil count of less than 500. Or sometimes patient comes to the hospital, they are for example, neutrophil counts at 900, which is not less than 500, but we are anticipating them that they will drop further. How can we anticipate them? This is when we take the history of the patient and we check the electronic medical record or health records, and we find out the patient received chemotherapy, let's say 10 days ago. So we are not expecting this patient to recover in the next 48 hours. We are anticipating this patient to go further down, decline in neutrophil counts. The patient comes with a fever, and let's say the neutrophil counts of less than 9, we consider that as febrile neutropenia. So, what are the risk factors for the febrile neutropenia? Of course, the chemotherapy. There's different types of chemotherapy. Some chemotherapies are gentle on bone marrows and not going to cause the febrile neutropenia in a lot of patients. The chemotherapy which are very toxic, like hyper-CVAD chemotherapy in ALL patient, AML induction, remission therapies, AML consolidation therapies. These are really tough chemotherapies. They're going to cause febrile neutropenia in almost 100% of patients. And those patients who have impaired immunity, and those who have poor nutritional status, for example, I found like a couple of studies, those patients who have hypophosphatemia, the opsonization and complement activation system is also impaired, and that also plays a role. The disruption of physical barrier, for example, mucosal barrier or skin barrier, due to chemotherapy, there are EGFR therapeutic EGFR inhibitor. There are lots of medication which breaks down the barriers. For example, tyrosine kinase inhibitor, they can break down the skin barrier. Chemotherapy can break down the mucosal barrier, so these can lead to febrile neutropenia with the bloodstream infections. Solid tumor versus hematological malignancies. So hematological malignancies are really tough to treat with, and they are treated with intensive chemotherapy. So they are at risk for developing febrile neutropenia, and actually we'll talk about that when we talk about the MASCC scoring system. Those patients who have splenectomy done, so there are risk factors, some genetic risk factors as well can cause febrile neutropenia. So when the patient arrives at the hospital, you have to act like a superman or superwoman, and you have to, I mean, you're not a physician, but you know, who wrote the febrile neutropenia guideline in my hospital? Actually, I was the primary author. So I wrote down all the instructions for the physician. So as a clinical pharmacist, although you're not going to assess the patient yourself, but actually you can put down the guidelines and it can help the physician, and it can always have a source of good information for them when to evaluate and how to evaluate. So you have to act like a superman or superwoman. So what you do basically, you have to take the history very quickly. You have to do the physical exam, like oral exam. You have to do like quick overview of the whole body, but you're not going to do the rectal exam because you can introduce lots of infection in a patient who has neutropenia. And you can look at the history of the patient, whether he has any comorbid condition. You can, of course, order lots of labs. You can order chemistry. You can going to order CBC. But you can obviously not wait for these lab results to come back to you, and then you start taking antibiotics. And you have to look at the history of the documented infection. For example, a patient who has a history of ESBL, you obviously have to select carbapenem up front as empirical antibiotics. And there's an antibiotic therapy or prophylaxis. For example, a patient who has received quinolone prophylaxis probably is at the risk of developing resistant gram-positive infection. You might have to consider vancomycin for those kind of patients. And of course, you can do the radiology assessment. For example, a patient who's having coughs, we can order like chest X-rays or maybe CT scan. But obviously, you're not going to wait for the lab results to come back to you in order to stop the antibiotic. That's the most important thing. When I joined this hospital, people were doing like one blood culture, and sometimes they were doing like one central line culture. So that's not the appropriate practice, because that can have like false positive or false negative cultures. So you are required to do the 2 blood cultures. One consists of 2 bottles. So preferably you need to take one peripheral and one central line if the central line is in place. If the central line is not there, then you can take blood cultures from the 2 peripheral sites from the 2 different anatomic sources. Or you can take from the 2 catheters, both cultures from the catheters. And other cultures you will take from patients presenting to you, like the types of the symptom. For example, somebody having burning micturations, you can order the urine culture. Somebody has like cough, dyspnea, you're going to order the sputum culture, bowel, etc. So all those investigations, you have to quickly scan the patient physically and order the investigation likewise. Okay, So one of the important things that you might have seen in febrile neutropenic patients, that not all febrile neutropenic patients, they have a documented infection, microbiologically documented infection. Sometimes you have like microbiologically, sometimes you have radiologically documented infection, but in around 60 to 70% of patients, you don't see any radiologically or microbiologically documented infection. And obviously, the reason in those patients is that, when there is a mucosal barriers are disrupted, a lot of cytokines and leukotrienes and inflammatory mediators are there, so which can cause fever. But we cannot say that this fever is not representing infection and we should wait until the culture is back. No, that we can take this can jeopardize the life of the patient, and patient can have significant mortality and morbidity. So we have to obviously treat all patients with empirical antibiotics. And you can see, like, this was the largest prospective observational study, which included around 2,000 patients. The study was published in American Journal of Medicine, in Antimicrobial Agents 2007. This has shown that the gram-positive organisms are more than the gram-negative, and the polymicrobial infections were 9%. And but the mortality was associated more with the gram-negative pathogens, 18% versus 5% with the gram-positive. The Pseudomonas aeruginosa is still the most notorious agent to target actually in febrile neutropenic patient. And the study had shown that around 1/4 of the patient had only febrile neutropenia episode with the bacteremia. So 23% of the patient diagnosed with the febrile neutropenia had bacteremia episode. So 77% of the patient had no bacteremia. We also published one of our resident, Dr. She was doing PGY1. I was her mentor, so I supervised her this research study. So we published this in one of the pharmacy journal of Sweden, and we found that only 19% of the patient had documented bacterial infection in our study. So that really simply tells you that the incidence of documented bacterial infection is about 20 to 30%, and the rest of the patients they do not have documented infection, but you still have to treat them empirically, and we'll talk about how that is later on. So these are the commonly cultured organisms that we find, like we find out gram-negative bacteria, and in our study we found like most of the patients they had E. coli, Klebsiella, and also Pseudomonas is common, and that is the most common cause of the mortality. So all the empirical antibiotic that you are trying to use for febrile neutropenic patients, you have to target. You have to use the antibiotics which cover Pseudomonas. We have the gram-positive bacteria as well, isolated in febrile neutropenic patients. The most common is the coagulase-negative staphylococci, Staph epidermidis, which you believe and I believe these are contaminant. But in case of a febrile neutropenic episode, you always have to believe that this is the cause of infection and you have to treat it. In general medicine ward, when you see this is coagulase-negative Staphylococcus aureus, you just ignore it, and you're not going to treat the patient. You look at the patient clinically, but in face of febrile neutropenia, you always have to treat it. Then we have MSSA, MRSA, strepviridin. This is one of the organism which is not covered by the ceftazidime. So whenever you are treating empirically patient with the ceftazidime, 2 gram Q 8 hours, this organism, strepviridin, is not covered by ceftazidime. So you have to add vancomycin in order to cover viridin group streptococcus. You're using ceftazidime. But if you're using other like tazocin, imipenem, meropenem, that's fine. They cover viridin group very well. And then we have C. diff. We are doing these days PCR, which is highly sensitive, and we have yeast and we have mold infection also, especially in AML, MDS patient or post-transplant patients, those who have graft versus host disease. So we see a lot of fungal infection. So for the risk assessment, I talked about Multinational Association of Supportive Care in Cancer risk index. So I attended one of the MASCC meeting in New York a few years ago, and they presented 30 years experience of febrile neutropenia with the validated tools. And their score is basically based on burden of illness, evidence of clinical instability or comorbid condition. We're going to describe it in a couple of minutes. History of prior fungal infection, site of medical care, age. And if the score is less than 21, it's considered high. And if high risk for febrile neutropenia, if the score is more than 21, it's considered low risk for febrile neutropenia. So that's the score I was talking about. It's mentioned in NCCN guidelines version 2 2020. So if the patient has no or mild symptom, the score is 5. And moderate symptom and severe symptoms are life-threatening situation, the score is 3. If the patient does not have hypertension, which means the patient does not have sepsis, the score is 5. And if there is no COPD, the score is 4. And similarly, hematological malignancy, solid tumor with no previous fungal infection, the score is 4. Those who have like previous infection, you're not going to assign them the score. And those patients who do not have dehydration and have outpatient status at the time of febrile neutropenia have 3 score. In a less than 60 is 2 score. So if this score is more than 21, then this is low risk. If the score is less than 21, this is high risk. NCCN guideline is recommending to use another scoring system, which is CISNI score model, which include ECOG performance status, more than or equal to 2. That means patient is bed bound, I mean in the bed, but less than 50% of the time, and they can go to the bathroom without the help of anyone. If the patient has breast-induced hyperglycemia, COPD, and others, if this score is more than 2, it's considered high risk. That means patient need to be admitted in the hospital and have to be treated with IV antibiotics. If this score is 2 or less than 2, then this is low risk. So NCCN is recommending to use MASCC scoring system and combine it with CISNI score model. And if both of them are suggesting this is low risk patient, so based on NCCN guidelines and ESCO guidelines, you can actually discharge the patient home on oral antibiotics. If the score is high risk, you have to admit the patient for IV antibiotics. Okay, let's move to the treatment part. So we have to treat the patient immediately. As I told you, there was a study which showed that administration of antibiotics within 60 minutes saves the life of the patient, reduces mortality and morbidity. And we at Ministry of National Health of Jeddah has given ourselves a tough task to administer the antibiotic within 30 minutes, and we're trying to achieve that. And of course, different institutions will have the different kind of empirical antibiotics used for the institution based on their antibiograms and cost effectiveness. And we try to choose the regimens which have the minimum toxicity, and these are the cost effectiveness. And we'll show you our guidelines as well. Okay, we talked about it, that administration of antibiotic less than 60 minutes of arrival in the hospital saves the life of the patient. So when you're deciding whether to admit the patient or to discharge the patient on oral antibiotic, you can use these parameters. So the patient, those who are high risk, they are the patient who are expected to have neutropenia lasting longer than 7 days. So less than 500 neutrophils and lasting more than 7 days, they are having profound neutropenia, which is neutrophil count less than 100. And the patients are clinically unstable, for example, having hypertension, sepsis, comorbidities, COPD, and patients were in the hospital at the time of fever. For example, most of the AML patient or the ALL patient during induction consolidation therapy. And those patients who have abnormal organ function are those who have grade 3 to 4 mucositis, and those who have the MASCC score of less than 21. So these are the patients who are at high risk of developing severe febrile to be treated in the hospital. Whereas the low risk patient, those who are like anticipated to have grade 4 neutropenia lasting less than 7 days, we're talking about solid tumors. Here we're talking about hematological malignancies. So the solid tumor, for example, breast cancer patient after receiving AC is not expected to have a neutropenia more than 7 days. So, and usually we know, we have seen from our study, most of the patients, solid tumor patients, their median time to achieve the difficult sense was 2 to 3 days, and most of the time they stayed in the hospital only 3-4 days, and then they went home. And they have no comorbidities. Our patient were outpatient. For example, patient takes R-stop or AC, and then they go home, and then they have fever, and then they come back. So they're at risk of they're at low risk of developing severe infections or sepsis during febrile neutropenia episode in comparison to patients who were actually inpatient, and those who have the MASCC score of 21. So these are the patients, if they have good GI function, you can give them antibiotics IV in the ER, observe them for 4 hours, and then discharge them on oral antibiotic. But these patients need to be admitted in the hospital. Okay, so for the outpatients, we have 2 options from NCCN guidelines. The option that we use in our hospital is ciprofloxacin 750 milligram Q12 plus augmentin 1 gram BID. I always recommend 1 gram BID. 1 gram BID has less toxicity, and 1 gram BID has less toxicity when you combine it with the meal. You will have less diarrhea. And NCCN guidelines also recommend moxifloxacin. It does not cover Pseudomonas, but in those patients who are at low risk of febrile neutropenia, low risk of severe infection in febrile neutropenia, so we can give them moxifloxacin. It's still category 1 recommended treatment option based on NCCN guidelines. But those patients who have received fluoroquinolone prophylaxis, moxifloxacin is not an option. But I would prefer levofloxacin if it's available. 750 milligram once daily would be much more better. And actually, levofloxacin, in my opinion, is equal to ciprofloxacin plus augmentin. So this is the ASCO guidelines published in 2018, and actually they recommended that those patients who have low risk for febrile neutropenia, they can have the IV antibiotics and within 1 hour of the triage, and they need to be monitored before the discharge on oral antibiotics like ciprofloxacin plus augmentin or fluoroquinolones. So for high-risk patients, this is IDSA recommendation, Infectious Disease Society of America. So they recommend high-risk patients should be admitted in the hospital and should be treated. A1 recommendation is treated with empirical antibiotics such as cefepime, 2 gram Q 8 hours, imipenem, or meropenem, and piperacillin tazobactam. So all these 4 antibiotics have A1 category recommendation. Ceftazidime is not included in the recommendation for a couple of reasons. I told you, like, it does not cover streptoviridin, and it has the issues of autoinduction of the beta-lactamases against itself. Whereas the NCCN guidelines have the same recommendation as that of IDSA. So cefepime is category 1, imipenem, meropenem, tazocine, these are category 1 recommended treatment option. But ceftazidime is category 2B, which is the lowest recommendation from the IDSA guideline, from the NCCN guidelines. So this is the summary, like cefepime, imipenem, meropenem, piptaz, these are category 1 recommended empirical antibiotics, and ceftazidime is category 2B. So some centers are using dual therapy for high-risk febrile neutropenia patients, and Ministry of National Government Affairs Jeddah is one of those hospitals. The reason is our antibiogram. When we wrote the guidelines first time in 2009, we had around 15-20% of ESBL, extended spectrum beta-lactamases, which are not covered by tazocine or piptaz. So we included the amino acid amikacin to cover ESBL during the 48 hours. And if there is no documented infection after 48 hours, we actually stop amikacin. And if there is ESBL, we change both amikacin and tazocine to imipenem or meropenem. So based on the antibiogram of the institution, people can use dual therapy for the high-risk febrile neutropenia. But IDSA and NCCN guidelines do not have the upfront recommendation of the dual antibiotics for high-risk febrile neutropenia. You can choose a monotherapy, but the dual therapy is the choice of the institution. So you can choose one of the antibiotics, which I mentioned, plus aminoglycoside, or you can choose one of those antibiotics plus ciprofloxacin. And the patient had recently received fluoroquinolone prophylaxis. Those patients are probably not supposed to receive quinolone as well in empirical therapy. The patient also have penicillin allergy. Cipro plus clindamycin is an option for low-risk patient. And aztreonam, which covers all kinds of gram-negatives, plus vancomycin is the option for high-risk patients with penicillin allergy. This is from IDSA 2011 guidelines. Now, we sometimes use triple antibiotics in our hospital. So we have a guideline for febrile neutropenia guidelines. Either we use dual therapy, like most of the patients that receive dual therapy with thelocin plus amikacin. And some patients, they may receive thelocin plus amikacin plus vancomycin. So IDSA recommend, these are the indications to include vancomycin upfront from the day one in empirical antibiotic regimen. So that those patients who have hemodynamic instability, they have the evidence of severe sepsis, radiographically documented pneumonia, or they have the positive blood culture for the gram-positive bacteria, or they have clinically suspected serious catheter-related infection, or they have serious skin or soft tissue infection, or they have the colonization with MRSA, VRE, the patient, those who have severe mucositis, grade 2 to 4 mucositis, and actually I would add one more thing, that they were on quinolone prophylaxis. So these are the patient, basically we should add vancomycin upfront. And as we go along, if we find out there is MRSA, we can add vancomycin to the regimen. And if there's a VRE, we can add linezolid to the regimen. And if there's ESBL, as I mentioned, we can change thelocin plus amikacin to carbapenem. And if there's a KPC, now we see lots of KPC. So we have Evicaz available in our formulary. We can use Evicaz, which is ceftazidime plus avibactam. So avibactam, ceftazidime is very strong antibiotic. Ceftazidime was very good antibiotic, but the induction of the beta-lactamases against the ceftazidime becomes a problem. But that problem is solved by the avibactam. So Evicaz is effective against the KPC. And if there's C. diff, PCR is a fast technique with a turnaround time of a few hours. So if you get the result same day, you can add PO vancomycin to the regimen. So the patient, those who are low risk, we've been talking about is those patients who are low risk patients, like their anticipated neutropenia is less than 7 days, clinically stable. You can give them oral antibiotics. I mean, you can give them a dose of IV antibiotic and then discharge them after 4 hours of observation on oral regimen if they can tolerate. And then you can educate them and tell them that if they get any kind of fever, they can come back to the hospital. And the regimen is ciprofloxacin and augmentin. And you also have an option of using IV antibiotics, as we do not have good resources or home healthcare resources, and we do not have for example, patient goes home, we're not sure whether the patient is going to come back. So most of the time, because of the cultural issues, we're admitting the patient for IV antibiotics. So we give IV antibiotic, and if they have documented infection, definitely they need IV antibiotics. And some patients, those who have like nausea and vomiting along with febrile neutropenia, still low risk, but they cannot take oral antibiotics, so they need to be admitted to receive IV antibiotics. For high-risk patient, definitely, we talked about the definition of high-risk patient. We need to admit them and give them the empirical antibiotic, which we talked about. And as we go along, if they have any other infection, we can adjust the regimen as I mentioned in my previous slides. So these are the doses. Cefepime is given 2 gram IVQ 8 hours. So as a clinical pharmacist, you really need to make sure that the doses given are appropriate. Sometimes I see like cefepime is not given like anti-pseudomonal dose. So all the doses that are used for empirical antibiotics are the doses which are targeted against the pseudomonas. So cefepime anti-pseudomonas dose is 2 gram IVQ 8 hours. Ceftazidime anti-pseudomonas dose is 2 gram IVQ 8 hours. Thelocin 4.5 gram IVQ 6 hours. So you have to try to give the doses which are anti-pseudomonas doses. And all the antibiotics which are anti-pseudomonal antibiotics, they need renal dose adjustment. So you have to adjust the renal function, assess the renal function, and adjust the doses along accordingly. Imipenem dose is for 500 milligram IVQ 6 hours, and meropenem dose is 1 gram IVQ 8 hours. 2 gram is for the meningitis, but for the febrile neutropenia, 1 gram IVQ 8 hours is fine. Doripenem 500 milligram IVQ 8 hours is fine. Itapenem does not cover pseudomonas, so it's not approved for febrile. Amikacin, we use 15 milligram per kg in our center. according to ideal body weight. In an obese patient, we use adjusted body weight. Ciprofloxacin, we use IV 400 IV Q8 hours, R750 milligram Q12 hours. Levofloxacin, we don't have it. If I have it, I will use 750 milligram once daily. Vancomycin, we use 15 milligram per kg as per actual body weight every 12 hours in adults, but in young patients and adolescents, and actually try to use Q8 hours or Q6 hours because they try to clear it up faster. Daptomycin can be used 6 milligram per kg once daily, and linezolid 600 milligram IV or DO. The patients, those who are on daptomycin, you need to monitor the creatine phosphokinase to monitor for the rhabdomyolysis. And for linezolid, you need to be aware of the drug-drug interaction when the patients are taking SSRI, and because the serotonin syndrome is rare, but actually we have seen patients taking linezolid with the SSRI, they develop like serotonin syndrome. So basically, we give empirical antibiotics and we give the patient at least 48 to 72 hours, and we check the cultures, and then we try to see if there is no documented infection, we de-escalate the antibiotics. We stop amikacin, we stop vancomycin if there is no documented infections. And if there is a causative organism, then we try to treat that. And if there is underlying, for example, typhlitis, pneumonia, we try to treat that infection. And we see the patient clinical condition and the response to the treatment. If the patient is diffuse, no documented infection, we de-escalate the antibiotics. And if the neutrophil counts are recovered like more than 500, we can stop the antibiotic. If there is no documented infection and the patient is diffuse more than 50 hours. So that's the summary that I was talking about. The low-risk patient, if they have unexplained fever, and patients are having persistent fever, but they are clinically unstable. If they were outpatient, they can be hospitalized and they receive IV antibiotics. If they had fever, they became diffuse, no more fever, and they're culture negative. So we actually continue antibiotics in those patients until the neutrophil count is more than 500. For patients, those who have high-risk disease, and if they have the documented infection, then we forget about the antibiotic. We just try to choose the antibiotic which is susceptible to that organism. That organism is susceptible to that antibiotic, and we complete the duration. For example, if it's like, let's say, a gram-negative bacteria like E. coli, we can treat it for 10 to 14 days from the last negative culture. If it's MSSA, we try to treat it like 14 days from the last negative culture with IV antibiotics. And if it's unexplained fever and the patient has persistent fever, but clinically patient is stable, you don't need to change the antibiotic. The patient has become diffused and cultures are negative, and again, you have to continue the antibiotic for indefinite period until the ANC is more than 500. In case of solid tumor, this is usually 3-4 days. But in case of AML, during induction consolidation, it's sometimes 2 to 3 weeks. Sometimes you will be questioning to yourself, why I'm giving antibiotic to this patient. This patient is febrile for the last 28 days. The reason is that the patient is not yet has not yet come out of neutropenia. And those patients who are not responding, you definitely have to do some imaging, CT, MRI for those kind of patients, and try to locate this infection. And you can broaden your coverage of the antibiotics, and you find out if there is any source of infection radiologically, for example, fungal infection or bacterial infection. You try to broaden the coverage, like you add gram-positive coverage if it was not included before, and you can add antifungal therapy. For example, if there is a halo sign, a sign of mold infection or yeast infection. So antibiotic prophylaxis, generally we don't use in our hospital, like hematological patient, those who are admitted during induction consolidation. We have a statement, we have a policy or guidelines. These patients actually stays in the hospital. So as long as they're in the hospital, they are being monitored. If they develop fever, we activate the febrile neutropenia pathway. But if they go home, then we recommend actually these patients to be prophylaxed with antibiotics. The best antibiotic which is used as prophylaxis is fluoroquinolone. And actually, the best antibiotic in my experience is levofloxacin, which is not available in Ministry of National Health Affairs. So we can give them ciprofloxacin. The dose of ciprofloxacin will be 500 milligram Q12 hours. Generally, we should not be giving prophylaxis to low-risk patients because of the risk of resistant gram-positive infections. So there was one of the meta-analysis published in Annals of Internal Medicine 2005, which reviewed like 95 randomized control trial. 52 trials have shown that fluoroquinolone, when it was used as antibiotic prophylaxis, is significantly decreased all-cause mortality and infection-related. So when to add antifungal therapy? So if we have a patient, like typically hematology patients are patients those who have received an intensive chemotherapy or conditioning therapy after the transplant, they can have fungal infection. They are the perfect host of the fungal infection, particularly AML-MDS patients. So if they are febrile even after 4 to 7 days and there is no explanation for the fever, you do some kind of imaging and serum galactomannan, for example, you can do that. These laboratory markers and radiological investigation can help you actually find out what's going on. If there is hello sign, so what you can do, you can preemptively, for example, give them voriconazole. And if you have like evidence of, basically what we do like CT chest abdomen pelvis, and we find out anything, any clue of fungal infection, so we add fungal infection. We do not necessarily add antifungal for all patients, but if they have symptoms presented to us in investigations describing the pattern of fungal infection, so we can add caspofungin 70 milligram on day 1 and 50 milligram subsequently. This is the recommended empirical antifungal in our hospital and by the international agencies. We'll talk about that when we come to the IDSA and NCCN guidelines. So basically, this slide talks about exactly the same. Like those patients who are high-risk patients and there is unexplained fever, we see like whether they are receiving prophylaxis or not receiving prophylaxis. If they are receiving, for example, anti-yeast prophylaxis, then we have an option to choose a kind of candida, voriconazole, or whatever amphotericin product. So particularly, we'll go with the caspofungin in this setting. Typically, ALL patients are the ones who are receiving anti-yeast prophylaxis, and AML-MDS patients, they are on really anti-mole prophylaxis. So the principle is that if they are on fluconazole, you can give them caspofungin, you can give them voriconazole, you can give them amphotericin B products. But if they are on anti-mole prophylaxis, then, for example, posaconazole, then probably voriconazole or posaconazole would probably be not the right option as empirical antifungal. However, if you have like a radiological clue or serum galactomannan is positive, for example, the patient was on posaconazole, you can choose voriconazole in those patients, or you can choose alternative, for example, caspofungin and MBSOL. So the frontline empirical antifungal therapy in our institution and the other international guidelines, they are recommending to choose caspofungin. Still, fluconazole is mentioned as one of the options, alternative to caspofungin. But nobody is using actually fluconazole as empirical antifungal, although it's still listed in NCCN and IDSA guidelines. Our frontline recommendation is caspofungin. Why we don't use amphotericin B? Because of toxicity. It is associated with significant nephrotoxicity like hypokalemia, hypermagnesemia, and caspofungin is equally good. Actually, it covers mold, it covers yeast. If you have radiological and molecular clue, then you can step down to preemptive voriconazole use as not empiric therapy, I would say preemptive therapy in selected patients. So one of the study published in New England Journal of Medicine, quite old study, 2004, which compared caspofungin versus the liposomal amphotericin B products. And had shown that they have similar success rates, but however, the toxicity with the caspofungin was much more lower. So this is the NCCN guidelines recommendation for antifungal prophylaxis. For ALL, you need anti-yeast prophylaxis, fluconazole. For AML and MDS, the category 1 recommended prophylaxis is posaconazole. You can still use voriconazole. And patients who are post-transplant, like autologous stem cell transplant and allogeneic stem cell transplant without GVHD, fluconazole is the category 1 recommended prophylactic options. And those patients after allogeneic stem cell transplant with the graft versus host disease, the posaconazole is the category 1 recommended treatment option. We can still use a kind of condense or you can use Ambisome in all these patients as antifungal prophylaxis. However, the recommendation is of lower grade. So these are the antifungal with the doses. Fluconazole is used 400 milligram once daily. Traconazole 400 milligram twice daily. Posaconazole we use 300 milligram BID on day 1, and then 300 milligram once daily for prophylaxis. And actually the same is the dose which is used for treatment. Voriconazole, this is the treatment dose, 6 milligram per kg is the loading dose for 1 day, and then 4 milligram per kg every 12 hours. And a younger patient probably would need higher dose. And you need TDM for voriconazole and as well as for posaconazole to ensure the safety and efficacy of posaconazole and voriconazole. Posaconazole is different from voriconazole with an advantage of coverage against the mucormycosis, which is not covered by voriconazole. Otherwise, they are almost the same. And idolafungin, this is the treatment dose, 200 milligram loading dose and 100 milligram daily. And same is the prophylactic dose. And caspofungin, 70 milligram is the loading dose, 50 milligram daily. Micafungin, we don't have it here. I'm not familiar with the dose of the micafungin. But enidolafungin is much more cost-effective in comparison to caspofungin when it comes to prophylaxis. However, enidolafungin is not yet approved for febrile neutropenia, but caspofungin is approved for febrile neutropenia. Then we have different amphotericin B products. I'm not going to talk about this. It's conventional, and Abelset we used to have in our formulary. 5 milligram per kg per day was the treatment dose, and the prophylactic dose in our hospital was 2.5 milligram per kg 3 times per week, which I recommended based on one of the MD Anderson Cancer Center protocol. We have been using it for 10 years, and then we published the study as well. I'll share with you. And recently we have replaced Abelset with the Ambisome. You can use a dose of 3 to 5 milligram per kg per day as treatment dose, and prophylactic dose. If you want to use, you can use either 1 milligram per kg per day daily or 2.5 milligram per kg 3 times per week, based on the extrapolation of the data from the MD Anderson Cancer protocol. This was the study. One of our resident, Dr. Reem Al-Mutairi, a very enthusiastic and energetic resident, mashallah, tabarakallah. I was her research mentor, so we actually she actually published this abstract in ACMIL 2020. She was supposed to go to Paris, but actually she didn't make it because of the COVID-19. However, abstract got published, and that's really amazing success, and her manuscript is ready and published soon. So basically, what we did, we evaluated the efficacy of posaconazole versus voriconazole as antifungal prophylaxis for AML and MDS patients. So we looked at the breakthrough invasive fungal disease in AML MDS patient who received invasive induction consolidation therapy. And this was the second primary endpoint, and the secondary endpoint was the discontinuation raised it to ADR, and we had a total of 48 patients. By the way, this is the third study for comparison between the voriconazole versus posaconazole, and this study is really of huge attraction by international infectious disease society, and people from US and North America contacted us manuscript and detailed information, because there is not much data on the comparison between posaconazole versus voriconazole. Still, posaconazole is category 1 recommended prevention option in NCCN guideline. Have a look at the results. So the rate of infection disease was 8% in posaconazole arm, and it was 6% in voriconazole arm. P-value was not significant. The rate of the discontinuation was slightly more with the voriconazole, but have a look at the cost comparison. So if we would have used voriconazole for all these patients, we would have spent only 175,000 reals only. And if we would have used posaconazole for all these patients, we would have spent like 1.13 million reals. So it's 6.5 times more cheaper with the same efficacy and almost the same tolerability and the safety. So based on this, actually, we can go ahead and recommend voriconazole comfortably as a fungal prophylaxis in AML and MDS patients. Posaconazole is much more expensive, and it's just equally effective. But only thing is mucormycosis. If we do not have mucormycosis cases in our hospital, in your hospital, you can use voriconazole as a prophylaxis comfortably. We had another very enthusiastic and energetic resident, Dr. Afnan Al-Amri. I was a research mentor. So in ALL patients, we had been using hyper-CVAD chemotherapy in patients those who were more than 25 years of age. And our frontline prophylaxis was NTG's prophylaxis, fluconazole 400 milligram once daily. However, we had problem actually in some patients, those were like Philadelphia positive ALL patients. They were on dasatinib, imatinib. So there were like drug-drug interaction resulting into QTc prolongation. So I looked at the evidence from the MD Anderson cancer protocol, and I found out like they are using Abelset or Embisome as antifungal prophylaxis. I started using this protocol, Abelset 2.5 milligram per kg 3 times per week in 2006 and 2006 or 2007, and we continued this practice for about 10 years. And then actually I found out that practically we had only 2-3 cases who had like QTc prolongation. So why not to do this study and see like how many patients we had like QTc issues, and we had around 60 patients. They received like 105 chemotherapy cycles, and with the 2-to-1 ratio of enrolling the patient in fluconazole versus Abelset, and we found out the breakthrough fungal infection was seen only in 3 patients, microbiologically documented in 2 patients, and radiologically documented in 1 patient. Actually, these patients were having infection prior to coming to the hospital, before the diagnosis. I mean, at the time of the diagnosis, they had some kind of radiological clue, and the other patient had like a microbiologically documented infection. And at one of the patient was actually, we had breakdown. We had like a crisis of mucormycosis in 2011. So one of the patients was from there. So basically, we found out like there's no big difference between the efficacy, and the QTc prolongation was also found in 13% patients with the fluconazole and 9% with the Abelset, because Abelset can cause hypokalemia and hypoglycemia. The p-value was not significant for that. So based on that, and also we looked at the cost comparison, and we found out like Abelset is much more expensive in comparison to fluconazole, and the difference is more than like 2 million reals per year. So we recommended like we will continue using fluconazole. This abstract was published in one of the journal, I forgot the name of the journal actually, and has been accepted for publication in Annals of Pharmacology and Pharmaceutics. Okay, so we move to the last part, which is the antiviral prophylaxis. So leukemia, we generally recommend the HSV prophylaxis for multiple myeloma, and those patients who have received proteasome inhibitors, and those who have received bone marrow transplant, we recommend VZV prophylaxis. That means cyclovir 2, 800 milligram BID, or IV is 250 milligram per meter square, Q12 hours. And the duration of antimicrobials, we discussed it. For patients who have no documented infection, we wait until the counts are recovered, then we stop it. And for the documented infection, we continue the treatment for the recommended duration. Growth factor support is significantly important for patients with who are receiving intensive chemotherapy. So ASCO, American Society of Clinical Oncology, they are recommending to use growth factor like filgrastim in patients who are receiving regimens which are associated with 20% or higher incidence of febrile neutropenia, for example, hyper-CVAD induction regimen for ALL patients. So they should definitely receive filgrastim, and some patients actually you can give filgrastim to maintain the dose density and dose intensity, and also during the COVID-19 pandemic situation, NCCN guideline recommending to use GCSF to prevent neutropenia and COVID-19 related complications in cancer patients, even if the incidence of the febrile neutropenia is less than 20%, like 10 to 20%. In our hospital, we have Neupogen filgrastim, and we have biosimilar filgrastim, which is much more cheaper and equally effective. And also we have PEC filgrastim, which is 1 single dose, 6 milligram, and effective for 14 days. And for the prevention, we use like 300 microgram or 5 microgram per kg 24 hours after the chemotherapy was finished, the last dose of the chemotherapy. And this is the indication. Those patients who are receiving chemotherapy regimens, and they are known to have for febrile in more than 20% patient according to the reported literature. So they are the candidate to receive the GCSF. For the management of the febrile neutropenia, none of the guideline is recommending to use filgrastim for the management of the febrile neutropenia because the use of the filgrastim has not been associated with survival outcomes. So none of the study until now has proven that there is any survival benefit associated with the use of the filgrastim for management of febrile neutropenia. But I use always filgrastim for the management of febrile neutropenia based on this study, and I'll show you the parameters. Economic parameters. So this study had shown that there is no survival benefit associated with the use of filgrastim for the management of febrile neutropenia, but it reduces the grade 4 neutropenia by 2 to 3 days, 2 versus 3 days, like by 1 day, and antibiotic therapy by 5 versus 6 days, like 1 day, and the hospitalization by 2 days. So I use this economic parameters in the calculator, and I found out like 1 day of the hospitalization in the non-ICU is 1,500 reals. 1 day of the IV antibiotics in my hospital is 2,000 reals. 6 days of IV antibiotics is 12,000 reals, and 7 days cost of the hospital is 10,500 reals. So the direct cost of the febrile neutropenia episode without GCSF is 22,500, and if I use biosimilar filgrastim, which is much more cheaper than the Neupogen, it's going to cost actually even less than 480 reals. So if I use filgrastim, we'll spend 16,000. If we do not use filgrastim, we'll use more money. So we'll be saving around 6,500 real per febrile neutropenia episode per patient if we use filgrastim. Not only this, in one floor, we'll be saving 150 to 300 admission days per medical oncology floor per month, which has significant hidden value in terms of the cost saving. So based on this, I strongly recommend to use biosimilar filgrastim for the management of the febrile neutropenia, which does not only save the money, but also save the admission days. So this is the guideline. I just wanted to show you the role of the clinical pharmacist in the febrile neutropenia. So who is the primary author in writing the febrile neutropenia guidelines for our institution? It's one of the clinical pharmacists, the one who is presenting to you febrile neutropenia right now. So we had the objectives to reduce the morbidity and mortality of the patient with febrile neutropenia, and to provide evidence-based and optimal care for the patient with febrile neutropenia, and to reduce the emergence of the antibacterial resistance in adult hematology oncology population at King Abdulaziz Medical City, Western Region, and we have been doing quite well. And clinical pharmacists have a significant role in the clinical pathway. They have to review the antimicrobial treatment, monitor the response rate, and they have to, this is the pathway which tells you, no, this is the protocol, I mean. So we give tazocin plus amikacin, or tazocin plus amikacin plus vancomycin when there is indication for the vancomycin. And here is the role of the clinical pharmacy which comes into place. From the day 2, clinical pharmacists have to tick the pathway on a daily basis, monitor the patient, and sign it here. On day 3 and day 4, the clinical pharmacists have to, until day 4, his role is there. So 3 days, day 2, day 3, day 4, he has to review the patient, and officially they have to sign in the clinical pathway. We had been doing it quite a number of years. However, when we moved to the new system, this system is on hold until we implement the pathways in the new health information system. So this was the study which looked at the compliance to the febrile neutropenia guideline, which was published in Swedish Journal of Pharmacy by our resident, who is now infectious disease clinical pharmacist, Dr. Dua Naeem. You know her very well. This study looked at the compliance to the guideline and reported the non-compliance, and then we went back to the end users, and then we tried to address those issues, and we are doing fine. So as summary, neutropenia and fever is a problem associated with increased morbidity and mortality in cancer patients, and it's a medical emergency. As the patient comes to the hospital, it has to be immediately treated. It's defined by neutrophil counts in the fever episode, and you definitely need the laboratory and radiographic and microbiology data as the patient comes to the hospital, depending upon your physical presentation, physical examination. But you don't have to wait for the investigation to come back to you to start the antibiotic. You have to take action immediately and see the results later on. And the choice of the antibiotic versus monotherapy versus dual therapy depends upon your institutional antibiogram, and then you'll be modifying the antibiotics, antimicrobial as you go along, and you see the microbiology of the patient, and you adjust the antibiotic based on the clinical picture as well as the recovery of the absolute neutrophil count. Filgrastim plays significant role in minimizing the morbidity and mortality associated with the febrile neutropenia, and also when you use it for management of the febrile neutropenia, it is cost effective, although it's not recommended by international guidelines. With that, I would like to say thank you so much. Thank you so much for your attention.
Dr. Mansoor, for the great comprehensive lecture, and we can open the questions, and if anyone have any question. And I have two questions actually. The first one, you mentioned in your slide that we can use moxifloxacin for outpatients, but not sure how we can trust moxi while it's not covering Pseudomonas.
Yeah, that's true. The low risk patients are those patients who are like very low disease burden, and they are solid tumors, not hematological malignancies. They have no risk of fungal infection, and they have no significant risk of Pseudomonas infection as well. Although I'm not happy and comfortable with this recommendation, but this NCCN category 1 recommended option, and I think it's okay. We had not been using in any patient, but we had been using in some patients like as a de-escalation or step-down therapy.
Okay.
Like those patients who have not been recovered from the neutropenia point of view. Like, for example, they have a neutrophil count 300, 400, still increasing. So maybe you can start them on moxifloxacin until they recover. So, but you know, I'm not comfortably recommending it for high volume disease or those patients, AML, MDS, ALL patient, hematological malignancies. No, I'm not going to recommend it for them.
Okay. Thank you. The next question is when we should stop antifungal if we started for febrile neutropenia after after 4 days of appropriate antibiotics, still the patient's febrile.
Excellent question. So after 4 days, you do not necessarily start antifungal in all patients. So you try to locate the symptom. For example, patient having abdominal pains, you try to do like CT chest, abdomen, pelvis. Try to scan the whole chest, abdomen, pelvis. If you find out any clue, then you start the antifungal. If you do not find any clue, you obviously do not start the antifungal. Sometimes you may start like based on like patient is persistently having fever, and patient like AML, MDS patients. So typically those kind of patients, we start them like blindly on, for example, caspofungin. So these are the patients do not have anything to treat with. So once they recover, you can stop antifungal. And those patients who have given you clue, for example, they have the clue of intra-abdominal infection, most likely like candida infection, or those who have like halocine, or like, for example, respiratory aspergillosis based on radiological investigation. Yeah, obviously you have to go by CT scan. So what we do CT scan every 2 weeks. And if there's collection, for example, intra-abdominal collection, so we monitor the intra-abdominal collections. When it comes down to 0, then we stop it. And if, like, for example, consolidation, bilateral opacities, ground glass appearance, or halocines, so of course we monitor the CT scan every 2 weeks and compare it with the previous CT. And if there is improvement, we continue it. If there is progression, we add something or we change antifungal. And if there is complete disappearance, then we can stop it.
Okay, thank you. Anyone has any other questions? No questions? Okay, thank you, Dr. Mansoor, again for your valuable time. We learned a lot, and that's it.
Thank you so much, Dr. Khan, and everybody else who attended. So we had almost 11 participants. So thanks all of you, and wish you good luck to take Saudi Commission exams.
Thank you.
And would like to see you, our colleague, very soon, inshallah. Thank you so much. Okay, assalamu alaikum.